My name is Mittleider. I'm a physician working with vascular and interventional physicians with Spectrum Medical Group. I'm an interventional radiologist and I'm the director of vascular and interventional radiology. So uterine fibroid embolization, it's a minimally invasive procedure that allows us to offer symptomatic relief to women who are experiencing troubles from uterine fibroids. The symptoms that women could be experiencing can vary wildly. It can be that they have pelvic pain, it can be that they have heavy menstrual periods, and it can be that their periods are becoming more frequent and heavier. We have patients at the far end of the extreme who are anemic and have needed blood transfusions, but your average patient isn't going to be that severe. For these patients, it allows a non-surgical option in order to control their symptoms. Everything can be done through a small tube that's inserted in an artery in the wrist, and the procedure can be done on an outpatient basis. And we use tiny little beads to block the blood flow to the tumors that are growing in the uterus so that these tumors die and the woman preserves her uterus and potentially preserves the ability to even have children in the future if she so desires. And she avoids the need to have a hysterectomy and the time away from work and the potential complications that can come from a much more major surgery than that would be. So the typical time, if you look at studies that have been published over the past 15 to 20 years, the typical time that women are out of work after uterine artery embolization is 9 days on average. We've had patients who go back to work sooner than that, and we've had patients who needed to go a little bit longer than that, but that's going to be your overall time that you're away. So the average time for hysterectomy for return to work is going to be about 6 weeks' time, so you're cutting almost 5 weeks of your recovery off of the procedure afterward. I break it down for every patient based on what she can expect before the procedure, during the procedure, and after the procedure. And beforehand, there are medications including a scopolamine patch that we put on to help with nausea. So during the procedure itself, a woman can expect, we let her know what the room is going to be like that she's going to be in, the sedation type that we're going to use. During the procedure to keep her comfortable, we emphasize again that everything is done through a tiny tube and there are no incisions anywhere in her body. We inject the beads using a very low dose of X-ray to see where the beads go. And then once we're confident that we've provided enough of the beads in order to block flow to these uterine tumors, then we remove the tube from the wrist and a small little balloon is inflated on the wrist and the woman can get up and walk around immediately. So she's not restricted to bed rest afterward. If she wants to get up and go to the restroom, she can. If she wants to sit up in bed and eat, she's able to do so. Most patients are going to stay in the hospital overnight afterward, but there's going to be a group of patients who can go home after the procedure if her pain is well controlled with oral medication. And then after the procedure, I tell every patient that for about a week after the procedure, she's not going to be my biggest fan because it's going to be the symptoms that she had before. It's going to be like a particularly bad period where you're going to have cramping and you're going to have pain. We give you oral narcotics to control the pain, and we also have you take anti-inflammatory medication to control the inflammation that's exacerbating the pain. And then once about a few days are over, that's typically when the worst of it has passed. By a week, a woman should be approaching her baseline as far as activity, and it would be unusual after 2 weeks to have significant pain left over from the procedure. And then we usually see improvement of symptoms kind of in a tiered effect afterward. The first symptom that goes away for most women is going to be urinary frequency. That the thought is that the fibroids are stealing so much blood flow from the pelvis that the bladder is constantly in a starved state for blood. And once you cut off the blood flow to the fibroids, then that sense of needing to urinate all the time improves rapidly. Pain and reduced periods are going to happen relatively quickly afterward. A woman's period may reset within the first month. It may take several months to reset, but it should reset at a lower level within 2 to 3 months after the procedure. As far as bulk symptoms, which for some of our patients are going to be the biggest complaint, that their uterus is simply so large that that's what's causing them their most difficulty, that is something that's going to take the longest amount of time to resolve, and that can take 6 to 7 to 8 months. And what we typically say is that a woman can expect to see a 40 to 50% decrease in uterine volume following embolization at that 6 to 7 to 8 month period afterward. Any woman who isn't already referred to see an interventional radiologist to talk about uterine fibroid embolization can absolutely self-refer. It's a procedure that has level 1A evidence supporting it. The Association of American Gynecologists recommends it as a first-line therapy for symptomatic uterine fibroids. And so it's something that is an accepted alternative to hysterectomy. If a woman has symptomatic fibroids, there's no specific contraindication to uterine artery embolization that she would already know about. As part of the workup for the procedure, we typically do an MRI in most candidates, and that is to look for that very small select group of women who may have something about their body that makes them not a suitable candidate. But that's something that wouldn't be apparent to a typical woman, and it just has to do with how the fibroids are growing off of the uterus, or how the blood flow is in the uterus, and also how much blood flow the fibroids are getting themselves. All those things kind of play into it. But I can tell you, out of the patients that we see for this procedure, the overwhelming percentage of them are candidates for uterine artery embolization, regardless of age, regardless of size of the uterus. In all honesty, the largest that I personally have embolized is a woman whose uterus was so large it was the size of a full-term twin gestation. Came up to her diaphragm, and she did very well after uterine artery embolization to control her symptoms. So these procedures can be done at any of the sites where we treat patients. We do them here in Portland at Maine Medical Center. We do them in Biddeford at Southern Maine Health Center. And we also do them in Lewiston at St. Mary's Regional Medical Center. All three of those sites are available to patients, and we draw patients from all over the state to provide this service. What I would really emphasize with uterine artery embolization for women is that, one, even if someone doesn't tell you about it or directly refer you for it, that doesn't mean that you can't direct yourself to at least have a conversation about the procedure. It may ultimately not be what you feel is the best choice for you, but you at least deserve a conversation about it as an option. And it's something that allows people to really have a minimally invasive non-surgical procedure to control, in over 90% of women, all of their symptoms long term, and to allow them to get back to their lives as quickly as they can.